Well, thank you everybody for sticking with us. In these last two talks for today, we're going to be focusing on narrowing in on the spectrum of GI problems that occur in neurodevelopmental disorders and autism. As we saw earlier, some of these effects can be quite broad and severe. The first speaker I want to introduce is Dr. Kathleen Model. She's been a long-standing advocate in the Rett syndrome community, and we're thrilled to have her participating today. Dr. Model is a pediatric gastroenterologist, and she works at Texas Children's Hospital and Baylor College of Medicine. One of her main focuses is nutrition, and she also has studied the stool microbiome and how that affects families with children with Rett syndrome. She's been a tireless advocate in the Rett syndrome community for the past 25 years. And she's going to tell us today about her observations in that community and what she's learned working with families. Welcome, Dr. Model.
Well, thank you for inviting me to speak today. Let me bring up my slides. So the title of my talk this afternoon is Growth and Nutrition Difficulties, Lessons Learned from Rett Syndrome. Before I begin, I need to tell you that I am a consultant for Acadia, which is the company that sponsors the trials for trofinetide, and I'm a section editor for Up to Date, which is an electronic medical textbook. I have no financial relationships with companies to disclose, and I'm not going to discuss unapproved commercial products. I do need to disclose, however, that the International Rett Syndrome Foundation has funded many of the studies which I will discuss today in Rett syndrome. My objectives for today are, one, to recognize nutritional deficiencies in neurodevelopmental disorders, and I'm going to use Rett syndrome as the model, to identify trigger signs for assessment, to identify clinical assessment tools, and then to identify approaches to assess those nutritional interventions that might be applied. This slide summarizes the growth and nutritional problems in Rett syndrome. Growth abnormalities, including short stature and malnutrition, are found in at least 62% of individuals. Feeding problems, including chewing and swallowing difficulties, are found in 81% of individuals with Rett syndrome. And low bone mineral mass, particularly low bone mineral density problems, are found in about 59% of individuals with Rett syndrome. Abnormal growth patterns are pervasive throughout Rett syndrome, as you can see with the blue lines on this graphic slide. Weight decreases by 6 months of age, height by 17 months of age, and the BMI is lower than reference standards. The pubertal increase in height and weight are absent in individuals with Rett syndrome. And we know that poor growth is associated with worse developmental delay and higher disease severity. Growth abnormalities are due in part to poor nutrition. Energy imbalance, particularly inadequate dietary energy intake and altered energy metabolism, account for growth abnormalities in Rett syndrome. We know that dietary energy consumption is about 30% less than unaffected individuals. We know that lean body muscle mass is about 15% lower, and total daily energy expenditure and sleeping metabolic rates are equally about 15% lower in Rett syndrome. Energy expenditure for physical activity, including the stereotypies that the children have, are not increased. And we know that energy losses, particularly in the form of malabsorption, is not increased in Rett syndrome. Body mass index is the gold standard for the assessment of nutritional status in Rett syndrome. Body mass index is the ratio, or at least it's represented by the ratio of weight to height. And normal BMI for unaffected individuals is the 50th percentile. Normal BMI, however, for Rett syndrome is variable. In younger girls, normal BMI represents the 25th to the 50th percentile. In younger girls, the BMI, when it is normal, can actually fall anywhere between the 5th and the 25th percentile. The trigger for evaluation actually is a BMI that represents less than the 5th percentile. Another measure of practical significance is the suprailiac skin fold thickness. The tummy tuck, which is the suprailiac skin fold thickness, when it equals approximately 1 centimeter in width, is a good measure of nutritional status and actually approximates the body mass index. Inadequate dietary energy intake due to chewing and swallowing dysfunction accounts for the reasons why we find poor growth in children with Rett syndrome. The swallow function study is the gold standard to assess the functional performance of chewing and swallowing difficulties, and the risk of aspiration can also be evaluated by the swallowing study. The trigger for evaluating children with a swallowing function study is the queries related to choking with feeding or drinking and prolonged feeding times greater than 40 to 60 minutes. The approach to intervention for major weight loss or feeding refusals includes alternative feeding methods that are either enteral feeding tubes or button gastrostomies. The indications for thinking about alternative methods of feeding include a body mass index less than the 5th percentile, progressive decline in the body mass index greater than 6 months period of time, chewing or swallowing dysfunction, including aspiration pneumonia, or parental request when they have difficulty with feeding refusal, medication, or fluid administration. This slide illustrates the growth response after nutritional rehabilitation with gastrostomy feeding in Rett syndrome. Height velocity and weight velocity increase after aggressive refeeding, and these values can actually exceed the normative data for height and weight velocity. The approach to intervention for chewing and swallowing dysfunction is limited. We recommend generally occupational therapy or speech therapy for refeeding and practice with oral motor skills. We know that oral motor skills wane with advancing age, and the motto is, if you don't use it, you lose it. Thickeners can be recommended for thickening of thin liquids, but appetite stimulants generally are not indicated. We have limited anecdotal evidence of benefit with Vital Stim, but again, these types of interventions require additional study. Low bone mass is another problem in Rett syndrome that is related to nutrition. Total body bone mineral content and bone mineral density are lower in Rett syndrome compared with unaffected individuals. Low bone mass is associated with increased risk of bone fractures, and the prevalence of fractures in Rett syndrome is approximately 30% by the time our girls get to be 25 years of age. This prevalence is actually a fourfold greater risk of fractures in Rett compared with the general population. Low bone mass results from osteoblast dysfunction or decreased bone formation. Mice models of Rett syndrome show decreased numbers of osteoblasts, abnormal growth plates, and decreased cortical, trabecular, and calvareal bone formation. Bone studies using labeled tetracycline in girls with Rett syndrome showed decreased trabecular bone and slow bone formation rates. Osteocalcin levels in individuals with Rett syndrome show uniformly low osteocalcin levels across the age groups, as shown in this particular slide. We know that dietary deficiencies with respect to calcium and vitamin D are prevalent in Rett syndrome. We know that calcium intakes less than 90% of the dietary reference intakes in Rett syndrome are about 28%. The fractional calcium absorption is higher in Rett syndrome than unaffected individuals, and vitamin D deficiency in Rett syndrome is about 20%. Dietary calcium supplementation in Rett syndrome, when we exceed the dietary reference intakes, is associated with increased bone alkaline phosphatase and osteocalcin levels in prepubertal girls, again supporting bone formation. We know that the use of multiple vitamins, the use of commercial formula supplements, and increased numbers of servings of milk is associated with increased vitamin D levels in these individuals. Food frequency questionnaires that address servings of milk and dairy products and the use of multivitamin and mineral supplements is a useful parameter to address bone mineral mass issues. Laboratory tests such as calcium, phosphorus, ionized calcium levels, and parathormone levels usually are normal, but are ways to monitor bone mass issues. Serum 25 hydroxy vitamin D levels may be low, and serum 125 dihydroxy vitamin D levels may be increased in individuals with Rett syndrome, again supporting the increased need for dietary calcium. Dual energy X-ray absorptiometry, or DEXA, is the standard method to assess total body bone mineral content and total body spine or hip bone mineral density, but its use may be limited. This particular tool is difficult to perform because stereotypies often lead to motion artifact. Sedation may be required for adequate output of the data, and the DEXA often requires intervals greater than 1 year of study for outcome assessment because of the slow rate of bone mineral deposition in children with developmental disabilities. With respect to the approach to intervention, few guidelines exist for the approach to low bone body mass interventions in Rett syndrome. Non-pharmacologic interventions include dietary and physical activity interventions. Pharmacologic interventions include the bisphosphonate drugs, but long-term outcomes and issues like atypical fracture rates really are unknown. The approach to intervention often resides with dietary reference intakes for age, for calcium, which we recognize, milk and dairy products as monitored by their consumption and their relevance to reference intakes are good sources. We can monitor this by questionnaires. And when children do not tolerate milk and dietary products, calcium supplements can also be noted and used as part of their assessment protocol. The approach to Vitamin D deficiency, again, resides with the dietary reference intakes for age. Food questionnaires, again, are useful tools. Sunlight exposure and frequency of milk exposure are as good vitamin D sources are useful questions to ask. We can monitor exposure duration, and we can monitor serving sizes by food questionnaires. Again, when these sources may be deficient, we can always request information about supplement about vitamin D for any levels that are less than 20 nanograms per milliliter. The physical therapy interventions, again, reside with time elements. Non-ambulatory children can be monitored by supported standing with standing frames. They can be monitored with low magnitude mechanical stimulation platforms. For those children who are ambulatory, body weight assisted treadmill or assisted walking time studies can be used to assess their progress. So in summary, nutrition problems, including growth failure, malnutrition, feeding difficulties, low bone mass, are common and in neurodevelopmental disorders, including Rett syndrome. Nutritional problems often are caused by inadequate dietary energy, calcium, and vitamin D intakes, as well as chewing and swallowing dysfunction. Diagnostic tools and intervention strategies can be useful measures to assess in terms of their clinical outcomes and quality of life measurements. So I will stop here and we'll wait for questions later.